Thank you very much for those very kind words of introduction. I don't really know how to follow that up, whether I'm going to take my clothes off or, run around and do handstands. You can tell I'm from the UK because I'm the only idiot wearing a tie in Mombasa, where the temperature's like 30 degrees. So this is a complete change of focus. I thought that was a fabulous talk about lupus nephritis. As a diabetologist, when we see anybody with lupus, we A, panic, and B, refer them to the nephrologists. So now I won't necessarily need to panic quite so much, but I'll still refer them to our nephrology colleagues. So I am a diabetologist by clinical practice, and as our esteemed chairman mentioned, I do quite a lot of research around epidemiology, health outcomes, in relation to sort of value for money and how we deliver the best care to our patients, identifying the right patient for the right treatment at the right time. And particularly from an economic perspective, this is really important. I don't know if you've seen the news recently. The British pound is worth a bag of peanuts at the moment. So I've got like about £10 in my pocket. So if anybody's got a bag of peanuts, I'll quite happily take it home and I'll go home a rich man. Anyway, so that's a little bit of background. By way of what I'm going to try to cover today, some of the points that I'm making. So, where have we come from with real-world evidence and RCTs? Now, we all know that the randomized controlled trial is the kind of gold standard evidence-generating activity to inform clinical practice, right? Now, over the last 5 to 8 years or so, the regulators have started to move towards assessing the role of real-world evidence to support a variety of therapeutic considerations, including new label indications, as well as safety and also health economic perspectives. So that's kind of a little bit of a background. Now, you may well see this thing called the estimand concept. This is introduced from a regulatory viewpoint to get rid of the whole concept of last observation carried forward, which is a bit of an arbitrary way of looking at efficacy endpoints. So the whole point of having the estimand concept was move the randomized controlled trial world forward such that when we assess efficacy outcomes, we're assessing efficacy outcomes, or whatever they may be, based on people who are actually on treatment at the time of the end of the study, rather than people who had treatment at some point during the course of that study. So that's a little bit of a background. So in terms of a regulatory viewpoint, what the FDA says is that real-world evidence is the clinical evidence about the usage, benefits, risks of any medicinal product set in the context of real-world clinical practice. And real-world data is the data that supports that evidential analysis. So you'll often see real-world data and real-world evidence discussed in sort of randomly, but they're two different things. The data informs the evidence. The evidence is our analysis of that particular data. So what is real-world evidence? So in essence, real-world data, as I said, is any data gathered outside of the constraints of a randomized controlled trial. And real-world evidence is effectively the analytical process that we apply to that data. And there's a variety of things that we can do. We can look at safety outcomes, we can look at post-marketing adverse events, we can look at supporting clinical trial outcomes. We can do a whole load of things which I will go through very briefly with you. So what sources of real-world data exist? Well, there's a variety of real-world data sources out there. Let's go back a slide. I'm a bit too frisky with the old slide changer here. It's the tie. But basically, if you look at this, there's a variety of different sources. We were discussing this last night. Kenya, I think you'll be rich in real-world data, and analysing real-world data be really important to inform local clinical practice here. Because what you tend to do is look at real-world data or RCTs derived typically outside of the region and try and sort of translate that into what might be pertinent in terms of regional outcomes. So you can have patient registries, electronic health records, administrative data, or survey data. And lots of people here are covered by insurance policies, aren't they? So there are a lot of insurance databases that will reflect health activity of a whole load of patients, and they're an extremely rich and useful source of real-world data. So, in essence, the difference between an RCT and a real-world evidence study is pretty straightforward. RCTs are very strictly conducted, set in the context of strict protocols, good clinical practice, etc., with standardized follow-up, standardized endpoint collection. Real-world evidence studies are completely different. They're a mishmash of studies set in the context of the constraints or otherwise of routine clinical practice. So, for example, if you're looking at managing lupus nephritis in a real-world setting, all of the different things that we've talked about, different steroid doses, etc., would all be captured in terms of the real-world outcomes, whereas you wouldn't necessarily be able to see that in an RCT because you have to follow a pre-specified protocol. Now, real-world evidence studies, therefore, are very helpful in extending on from the observations of any RCT, be that in diabetes, cardiovascular medicine, nephrology, dermatology, respiratory disease, whatever the condition may be. Real-world evaluation of that treatment in that condition is extremely helpful to inform practice and whether we are doing the right thing. So, and the reason for that is RCTs have very, very strictly defined patient populations, whereas in the real world, you've got a whole range of people that aren't necessarily captured within the randomized controlled trial setting. Now, there are a variety of real-world evidence studies that you can do. You've got the phase 3 randomized controlled trial. So these are things like the cardiovascular outcome studies that we have in diabetes, EMPA-REG, Sustain 6, Pioneer 6, Rewind, etc., etc. We're all very excited by our outcome studies. But then we can have ongoing phase 3 studies set in the context of real-world clinical practice, where those people who are in the RCTs are followed up afterwards to see what happens after they have come out to the clinical trial. Then we have pragmatic randomized trials. These are the current concept from a regulatory perspective as the gold standard of real-world evidence. And interestingly, we were in a meeting a couple of weeks ago, actually, from a regulatory viewpoint, talking about how we can leverage real-world evidence, not only for safety or economic outcomes, but to support new therapy indications. And what they really want is these sort of pragmatic, randomized real-world setting studies, where basically what you do is people are given a new treatment versus what they would otherwise have been given, and are followed up in the context of routine clinical practice to see what happens, whether or not that supports a new indication. And that's kind of where regulators are at the moment. We can have prospective observational studies, and we can have retrospective database studies. So we started off with retrospective database studies, and we've moved through all of these different types of evidentiary analyses. And I'll show you some examples of different studies in a moment or two. But when we come to basically confirm why we do these real-world evidence studies, the real reason for this is that, as I said to you, the majority of people in studies are not reflective of what happens in routine clinical practice. These are the diabetes megatrials from the early noughties, and you can see that less than 20% of everybody that we treat with diabetes are included in these studies. No matter what people say, they're reflective, etc., they're clearly not. So we're making judgments on the basis of only a small snapshot, a picture, one little Polaroid. Whereas really, we want to make judgments on everything that we see. So it's like I've looked at a photograph of Mombasa and thought, I'll be fine to wear a tie. And I've come here and the picture is, I'm sweating my nuts off, it's really hot here. So, what have I done wrong? Well, what I haven't done is taken the full picture. So that's why I think it's really important that we have real-world evidence studies. And what differentiates an RCT versus a real-world evidence study is just kind of illustrated here. Real-world evidence studies, often longer term, based on what happens in routine clinical practice, and are a much broader spectrum of individuals compared to the RCT. So findings from RCTs and real-world evidence can differ, actually, for a variety of reasons. And these are the points here that will make these studies potentially different. Study setting, therapy adherence, placebo, population studies, as well as this concept of residual confounding. All of these are fairly obvious, aren't they? Because really what you want to see is what your treatment strategy, your technology, your therapy approach, your system of care does in the context of your routine clinical practice. However, in order to fully understand that, you have to understand this concept of confounding. And effectively what confounding is bias introduced as a concept of the process of prescription. Because if you think about it, you prescribe a medicine for a reason, right? And that can introduce bias when we are analysing the outcomes associated with that particular medicine. Now, one of the key things to bear in mind is whenever you look at real-world evidence compared to randomized trials, particularly in terms of efficacy endpoints like HbA1c, often the clinical trial will show much bigger A1C or efficacy outcome benefits than you might see in the real world. And that's because in real-world clinical practice, people just don't take their tablets, for example. There's a delay in follow-up, there's education, all of these sort of things that happen routinely in the context of a clinical trial. So when it comes to designing real-world evidence studies, there is a sort of good clinical practice protocol that has been developed in conjunction with regulators so that there's a standardization of approach. And we need to be monitoring, obtaining patient consent, addressing bias, and ensuring that we use appropriate study designs or data gathering to answer the appropriate questions. Now, the key thing that we use a lot these days is this thing called propensity score matching. So if ever you look at a real-world evidence study, you'll see we'll talk about propensity score matching. In essence, it's quite a straightforward thing. What you try to do is introduce the same kind of analytical approach that you'd have in an RCT, where you have two groups that are matched for as much bias-introducing, confounding variables as possible. So what you'll end up with, you'll have two cohorts, then these will be matched on the basis of as many variables as are captured within the data, such that eventually you'll have very similar cohorts that are compared to one another in terms of the endpoint that you are looking at, be that heart failure outcomes, be that HbA1c, blood pressure, renal outcomes, etc. And very typically, you'll start with a database of maybe 150,000 and end up comparing outcomes in about 8,000 or 9,000, simply because of missing variables that you want to match. In terms of types of real-world evidence studies, I've kind of covered this already, but you have physician surveys, chart reviews, database studies, prospective studies, and these pragmatic trials. These are the things that you're going to be seeing a lot more of in the context of new regulatory considerations for medicines that are out there. I'm just going to spend a moment now thinking about who gains benefit, who are the stakeholders for which these sort of studies are important, and what things can we learn from them. So first of all, we can get a handle on treatment and persistence, because you can have the most efficacious drug in a randomized trial, people don't take it, it's not effective. We can look at financial burden of disease. We can look at patient-reported outcomes, really important, because happy patients take their medicines, do well. We can look at clinical outcomes, heart failure, cardiovascular events, renal failure. We can look at quality of life measures, again, very important if you're paying for your medicine. We can look at psychosocial factors, we can look at healthcare resource issues, and we can look at value for money and cost effectiveness. So there's a whole load of parameters that we can look at within the context of real-world evidence data. Who are the beneficiaries of real-world evidence? Well, there's a variety. In fact, all stakeholders, I would argue, within the healthcare system can benefit from real-world evidence. Payers, healthcare professionals, regulatory bodies, and importantly, individual patients. Because the objective of real-world analyses is to ensure that the right patient gets the right medication. So I'm going to finish off for the last just few minutes, just illustrating where we've used some real-world evidence in diabetes, not nephrology, in diabetes. So don't have a go at me. I'm not a nephrologist. I did want to be a nephrologist years ago, but I really wasn't clever enough. Anyway, so this is a study that was done looking at the burden of hypoglycemia. So we can look at disease burden. And what this was a prospective study asking patients about how frequently they had hypoglycemia, low blood sugar. And what we're seeing was that it was actually much more common than we thought it was going to be. So prospective real-world evidence can capture disease burden. Database analysis, audit, can give you financial burden of disease. And once you've got financial burden of disease, you can start to work out value of intervention. If you reduce events, how much you might save across the healthcare system. So this is some NHS UK data looking at heart failure. 2% of NHS beds annually are occupied as a consequence of heart failure. 5% of all medical admissions. 2% of the total NHS budget. Do you know how much you spend in Kenya on heart failure? Anybody? No? So I think there is an important message to take home here. You have the data. If you use it, then you can get a handle on better service delivery and making most of what you have. So applying that, if we looked at the data from the SGLT2 inhibitor heart failure studies, EMPEROR-reduced and DAPA-HF, and applied that to those costs that we saw from a UK setting. If we treated patient population as reflected in the EMPEROR-reduced or DAPA-HF, you'd save the NHS these sort of monies. So you can get a handle using real-world evidence of the money you might be able to save. I'll show you some more examples of that shortly. This is a propensity score-matched study, the Evans.Real, which looked at people who are new users of an SGLT2 inhibitor for treating their diabetes versus those who didn't have an SGLT2 inhibitor. And these are outcomes such as cardiovascular endpoints, heart failure hospitalization in a real-world setting, demonstrating that the outcomes in the RCTs with the SGLT2 inhibitors are actually translated into tangible outcome benefits in routine clinical practice. You can also look at safety, and this is the risk of lower limb amputation with SGLT2 inhibitors across real-world studies. And what you will notice is, first of all, event rates are very low. Secondly, there is no significant signal for an increase in lower limb amputation. And this is largely because the confidence intervals span line of unity. So from a real-world evidentiary perspective, we can be reassured around the lower limb amputation issue with SGLT2 inhibitors. What about choosing the right drug for the right patient? So this is the EMPRISE study. Now this was, or is, a real-world propensity score match population study using 3 massive US databases looking at people prescribed either empagliflozin or a GLP-1 receptor agonist or a DPP-4 inhibitor. Just to remind you, that was the EMPA-REG outcome study from the RCT perspective, comparing sitagliptin with empagliflozin in routine clinical practice. Empagliflozin was associated with a relative risk reduction in terms of heart failure hospitalization to a similar extent, if not slightly greater, than that seen within the EMPA-REG study, confirming in routine clinical practice the utility of an SGLT2 inhibitor. When we look at that in slightly greater detail, say comparing those people with and without heart failure, no difference, consistent findings. So if you use an SGLT2 inhibitor such as EMPA in this situation, you'll get a heart failure hospitalization burden reduction, irrespective of whether or not you have it or don't if you have type 2 diabetes. When you compare EMPA with a GLP-1 receptor agonist in terms of heart failure hospitalization, all heart failure or heart failure specific, again, you see a reduction in favor of empagliflozin from the heart failure perspective. Moving on to something more cost-based. So this is the offset study just done by ourselves, published very recently. Now, you all heard of the ADA-EASD consensus, right? We all go on about it in the diabetes world, about if you've got high cardiovascular disease or established vascular disease, we should be thinking about a GLP-1 or a SGLT2 inhibitor. Showed you some SGLT2 inhibitor data. What about GLP-1s? Now, GLP-1s are quite expensive. So one of the questions is this going to give you value for money? So what we did in this particular real-world analysis was interrogated a US database for people with type 2 diabetes and established cardiovascular disease, given either a GLP-1 receptor agonist or something else, which interestingly didn't include an SGLT2 inhibitor. In fact, only about 9% of the people who were in the comparator group had an SGLT2 inhibitor. Now, what we saw was the drug costs were higher with the GLP-1 group, but overall, the totality of healthcare costs were actually lower, driven by the fact that if you use the GLP-1 receptor agonist, you reduce the potential for subsequent cardiovascular-related hospitalizations. And that was over a 12-month period. Another study very quickly that we presented at the EASD in Stockholm last week, which is considerably colder than here, I can tell you, was looking at the comparison in terms of stroke events for semaglutide versus a DPP-4 inhibitor. And this is part of this process of trying to leverage real-world evidence for a new indication. Now, semaglutide in both the Pioneer 6 and the Sustain 6 outcome studies showed a reduction in stroke. Was that something that we could see in a real-world setting? So again, what we looked at were people with type 2 diabetes with or without established cardiovascular disease who were prescribed either a DPP-4 inhibitor or semaglutide. This contained around 80% of people on the injection and around 20% on oral semaglutide. 25% of people in each cohort had background SGLT2 inhibitor. We used propensity score matching to match on the basis of 28 domain variables, such that the cohorts you'll see here are very closely matched. And what we ended up noticing was that there was a reduction in stroke incidence in those without as well as those with established cardiovascular disease. Admittedly, the event rates are low and longer follow-up than the 12 months are required from a regulatory perspective, at least, to use these data to support a new indication. And those are the Kaplan-Meier curves, just supporting the fact that the stroke reduction seen was quite an early manifestation of outcome benefit. So by way of summary, ladies and gentlemen, there are many different sources of real-world evidence. There is a growing recognition of the use and importance of real-world evidence. It is a source of information that's incredibly important for nearly all, in fact, all stakeholders within the healthcare system. And I think what's critical, and I know this has been a diabetes talk, and I know this has been a real-world evidence talk to a cohort of esteemed nephrologists, but my objective here was to try and get across the importance of understanding the implementation, analysis, and interpretation of real-world evidence can help all sorts of clinical decision-making across all sorts of different diseases. I've shown you some examples, and I'm happy to take any questions. Thank you very much for your attention.